Identifying IV therapy equipment. The winged infusion needle, or a butterfly or scalp vein needle, is stainless steel with one or two plastic wings that are attached to the shaft. A small segment of tubing is frequently attached behind the wings. You can obtain these in a gauge of 27 to 17 with a length of 2 to 13 inches. 13 seems awfully long. I don't know that that's even appropriate, but about 1 to 2 inches is really what I have seen in the past. We don't use it very often due to the availability of the plastic catheters because those allow a longer dwell time. Advantages are that the wings allow ease of insertion and securing, and they're also frequently used to draw blood. There are fewer incidences of phlebitis with these types of devices. Disadvantage is there is decreased mobility because there is rigidness of the device. In other words, the needle stays in the device or stays in the vein. There's not a plastic catheter that stays in the vein. And there's an increased infiltration risk. With over-the-needle catheters, this has a needle that has a catheter sheath with it. You can obtain that in a 12 to 27 gauge with a length of 5/8 to 3 inches long. After venipuncture, the needle is withdrawn and discarded, and the flexible catheter remains in the vein. It's what is used most commonly for IV therapy. Advantages are that it's less prone to infiltration and allows more mobility than the winged infusion needles. Disadvantages are that it's associated with phlebitis if there's an extended dwell time. These devices, the plastic catheter, can also kink if it's inserted in an area of flexion and there's not appropriate armboard protection. And it may be severe if improper techniques are used during insertion, so infection risk can be severe. With your midline catheter, it's inserted in a vein in the antecubital region, then it's advanced until the catheter tip terminates in the upper aspect of the arm. You can get this in a 16 to 24 gauge with lengths of 3 to 8 inches. It's used for therapies of 2 to 4 weeks duration, and it's composed of a polyurethane or a silicone material. Advantages are that it can be placed in large diameter veins of the upper arm because it allows for greater hemodilution of the infusate, and there is an extended dwell time. Disadvantages are that insertion techniques require special educational processes. Kansas IV certified LPNs cannot insert a midline catheter. With intermittent infusion devices, again, these are used for intermittent therapy, and it provides immediate IV access. Advantages is that it avoids multiple venous punctures. You have prompt venous access. It has the potential for decreased fluid overload. It is economical, and there's increased comfort and mobility. Disadvantages: you have the occurrence of clotting if you don't flush it periodically with a heparinized saline or saline solution. And there's a risk of drug incompatibility when heparin is used to maintain patency of the device. Central venous access devices are for patients that require multiple IV lines for continuous or intermittent drug infusions, for total parenteral nutrition or TPN, CVP monitoring, blood administration, venous sampling, simultaneous infusions of incompatible drugs or fluids, medications that have an osmolality of greater than 600, medications that have a pH of less than 5 or greater than 9, or vesicant therapy. Specific use of individual lumens as per manufacturer's recommendations and or established facility policy. In other words, sometimes with the CVP that goes in the distal port, so that's usually the brown port on your triple lumen. Advantages: One insertion site can yield 3 separate infusion exit points. Disadvantages: it requires insertion by the physician with a follow-up x-ray to make sure that proper placement is accomplished prior to it being used, and potential insertion and post-insertion complications. With the tunneled central venous access devices, it's used for long-term vascular access with the advantage of having an extended dwell time. Disadvantages: you've got the potential for infection. The device needs flushing at least once daily when it's not being used to maintain patency. The catheter can be damaged by sharp or serrated clamps or by exposure to increased PSI of pressure. There's a potential for occlusion. It may cause psychological distress from an aesthetic standpoint, and it also requires placement by a surgeon. An implanted central venous access device is used for patients that require long-term repeated access to the venous system. Advantages are that it's completely implanted. There's no dressing required when it's not being used. Heparinization is only every 28 days during periods of non-usage. There's a lower reported rate of infection. There's minimal interference with lifestyle, and it's cosmetically accepted by most patients. Disadvantages, again, is the risk of occlusion, the risk of damage if it's exposed to increased PSI pressure, infection potential, the portal reservoir pocket and or systemic infections. It does require surgical implantation and skilled, knowledgeable RN to access. With peripheral central venous access devices, these devices are composed of silicone or polyurethane. They are obtainable in a 16 to 23 gauge with lengths of 60 to 33.5 centimeters and come with a single or double lumen. The initial means of accessing the vessel for catheter placement, you've got the breakaway needle, a peel-away introducer sheath, and a micro introducer. The insertion site will be the basilic, median, cubital, or cephalic vein adjacent to the antecubital fossa. The catheter tip is then advanced to the superior vena cava at the third intercostal space. It's used when venous access is required, and it can be used for up to a year. Advantages is that it eliminates many of the risks associated with other central venous catheter placement. It's very easy to use, it's a reliable mode of vascular access, and it's well accepted by patients. Disadvantage is that it requires patency flushing. There's potential catheter damage if it's exposed to increased PSI pressure. And you need to be certain that certain PICCs can withstand increased PSI injection pressure, which would alleviate the previous disadvantage, but you need to be aware of manufacturers' recommendations. Dislodgement can result if dressing change is performed improperly. The Grishong central venous access device is a brand of catheter. It incorporates a patented 3-way pressure-sensitive valve. You have negative pressure, the aspiration, which opens the valve inward for blood sampling. Positive pressure by the infusion will cause the valve to open outward, and negative pressure valve that remains closed. The patency of locked catheter requires flushing with only normal saline, has the advantage of decreased risk of bleeding, decreased risk of air embolism. It eliminates the need for catheter clamping. The manufacturer specifies that the product should not be clamped at all. Then we have electronic infusion devices. Your standard electronic infusion pumps. If resistance develops, the pump will exert additional positive pressure to overcome the resistance, but it will not exceed its preset limit, which is called the occlusion pressure. Most pumps use microprocessor technology. General information about the pump is it has a range rate of 1 ml per hour up to 999 mLs per hour, but some specialty models will only go up to 99 mLs per hour and down to 0.1. Other models can deliver up to 2,000 mLs per hour. Usually you can change the infusion in increments of 1 ml, and the accuracy is plus or minus 2%. It has a battery life of about 8 hours. The maximum occlusion pressure will vary with the manufacturer. Usually it's about 4 to 15 psi. It will run at a KVO rate when the infusion is complete of 1 to 4 mLs per hour, and the displays will vary depending on the manufacturer. It may show volume infused, the dose delivered, a KVO rate, volume detector, occlusion, malfunction, excuse me, low battery, may show you that the door is open or the infusion is complete, in addition to other things. It is available in a multi-channel design for multiple fluid and drug administration. It's critically important to know if the pump has free flow protection capability. In other words, is it going to prevent the fluid from just running in, or is it going to allow the fluid to run in without stopping it? Don't rely on the pump alarm to detect IV infiltration or extravasation. It will let you know when there's a problem, but it doesn't always let you know when there's a problem. Again, with PCA pumps, these are programmable for continuous infusion, bolus infusions, or both. They have a remote control mechanism where the patient can deliver a patient dose or bolus. And again, with PCA pumps, always follow the manufacturer's specific instructions for the use of a particular PCA pump. General information, they have a rate range of 0.1 to 30 mLs per hour. It can be increased or decreased in increments of 0.1 mLs per hour. And there's programmable concentrations, and again, alarms will vary according to the manufacturer's specifications.